All right, and I'll just leave myself muted
Great.
until we get a question.
The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody. My name's John Rumpakis, and it's a pleasure to be with you tonight, and thank you for taking time out of your valuable day to share some time with us and learn about the healthcare environment. A couple of things before we actually get started. Number one, I would like to thank the IDOC leadership for putting on these 8 different webinars. As you know, tonight is number 1 of 8. You can contact IDOC for details of the upcoming schedule for the remaining 7 and the specific topics for each one of those. Just so you know, each webinar will be recorded and stored for 90 days after the original broadcast date, and they'll be downloadable on the IDOC website. So again, we will be recording all of these as we go through, and you can contact them for the schedule, topics, and then you'll have up to 90 days after the broadcast date to listen to them again. As far as mechanics for tonight, I'd like to introduce Nathan Hayes. He's also on the line from IDOC, and Nathan's going to be assisting me tonight in fielding questions as we go through. One of the things I'm a big fan of is being able to have questions come throughout the course of the presentation rather than waiting until the very end. I think if we wait to the end, the questions often lose their relevancy and to the matter in the talk itself. So please feel free to ask questions as we go forward. How we'd like you to ask the questions is in your box that pops up. There's a section there for questions. We'd like you to type your question in there and then submit it. And as we go through, when Nathan gets the questions, he will go ahead and alert me and ask the question, and we'll do our best to answer those as we go through the entire presentation. We anticipate that each one of these 8 webinars will be approximately 1 hour in length, so that way you can kind of budget your time on how you want to do these, but we've kind of created a very logical sequence as we go through, and we're very excited to kind of get started and talk about all of these things, because certainly the world of healthcare today is more challenging than it's ever been, but also I'd like you to think of it this way. There are more opportunities today than there's ever been as well. So with that, let's go ahead and get started on the presentation itself. Just a little bit about me. I've been out in the practice world here for about 33 years now I'm going on, and I am no longer in clinical practice. I sold my clinical practice years ago and pretty much have done consulting pretty much full-time since that point in time. I have a number of different businesses in the eye care space and really provide consulting to all of the major players in the eye care industry. This is a list of my disclosures, all the companies above the line. That's a partial listing of who I currently am doing work with. I don't have a financial interest in any of those companies, nor will you hear me talk about companies or advocate from the podium from them. I talk about concepts and policies only and compliance rules rather than advocating certain technologies or company-specific technologies. Most of you may know me from my columns in Review of Optometry and Optometric Management, where I hold the position of Chief Medical Clinical Coding Editor. I also write for many others: Ocular Surface News, Review of Cornea and Contact Lens, Office Economics, optometry, business, you name it. And again, down at the bottom are the different companies that I have ownership in. Not a conflict for tonight. We're not going to be talking about any of those things overall. If we talk about any numbers tonight, please understand that if you see a dollar value associated with a CPT code anywhere in our presentations, those are the 2017 national average Medicare maximum allowable reimbursements for each procedure as of today. If we talk about a policy regarding a CPT code, they will be current as of today. Remember that I can only answer, it's hard to answer general questions specifically or specific questions generally. So if you have a specific question, you're welcome to contact me individually. I'd like to know where you practice, so that way I can make sure when I give you an answer it's geographically correct as well. We're not going to be going through any coding protocols today, so you can not pay attention to the final bullet point. So before we go forward in this, I want you to write down one phrase, and I want this phrase to be everywhere that you look. I want it on your bathroom mirror. I want it on your refrigerator door. I want it on your windshield. I want it in the office break room. I want it on your personal office computer monitor. I want you to write this one phrase down, and I want you to repeat it over and over and over until you truly believe in it. And here it goes. Disruption creates opportunity. Very simple. Disruption creates opportunity. We can see historically throughout business that anytime that there's been a disruptor in the field, it's created opportunity in the same industry. In our business, we tend to only focus on eye care, and I respect that. That's what we do for a living. However, what I want you to understand is that there are many parallels in other business models that have been out there that we can learn from, and rather than have fear about changes that are taking place in the environment, we can embrace change. And we can understand that this disruption in our industry is going to create opportunity for those of us who are willing to be able to see the silver lining that could occur. I see a lot of people that tend to be fearful of change, and we'll talk about change a little bit later in more detail. But what we're facing right now is a huge fundamental shift, a paradigm change of massive proportions in the entire space of healthcare. It doesn't affect just optometry, doesn't affect just ophthalmology, but it affects you as a healthcare consumer when you go see your family practice doctor, your pediatrician for your kids, your OBGYN, your cardiologist, your endocrinologist. It affects everybody because a fundamental shift has taken place from the way we get paid in the healthcare system today as a qualified healthcare professional. And that means that it's a major shift from getting paid for quantity of tests or visits to actually how well you're able to get the patient to a better place. So what is outcome-based care? I challenge audiences to answer that question all of the time, and I think it's important for each and every one of you to answer it in your own way. Outcome-based care is going to mean different things to different people. Now, you're going to say to yourself, well, you know what, that only pertains to Medicare, or that only pertains, if you do a lot of medical eye care, and really, my bread and butter is optical, and that's what I do, and that's all I really care about. I'm here to tell you that you can't escape this, whether you're primarily a VSP, primarily a iMed, primarily a Davis Vision, primarily a Spectera, primarily a Blue Cross Blue Shield, primarily a Cigna provider. It doesn't really matter. This is a fundamental shift in how we get compensated. So I want to break this down because I want to talk about how disruption is going to create opportunity and what kind of things that you can be specifically aware of so that way you can understand that knowledge is power in this environment. Because you can know more than others by doing a little homework, doing a little extra research, listening a little bit more carefully, empowering your staff to do more things in your practice, you will understand that this disruption in the marketplace will create opportunities for your practice. Now, I'll tell you one of the major tools that you have. You're an IDOC member. You have resources at your disposal that are far and beyond what the average individual has. It's something I want you to understand and embrace, right? So that way you can understand that you can contact IDOC. They have resources. They have all sorts of different things that you can be able to apply to your practice to either control costs or to help market or to help train your staff. So remember, you're not alone in fighting this. You've got 2 million healthcare providers out there you're fighting this with. You're swimming in the same sea, so to speak, and you're a member of an alliance that has resources that can help you execute these things to perfection. So let's talk about outcome-based care and some of the headwinds and challenges that it creates. So, every year we always get these OBB, the Optical Business Barometer, that Jobson, as an example, puts out. Many of the publications put them out. I'm just using this one as an example, okay? Eye care, in the big scope of business, eye care is a $68 billion a year business. Yes, that's 68 billion with a B. That's all-encompassing, optical, surgical, everything, $68 billion. I want to put it into perspective a little bit more as we talk about this. As an optometrist, we provide 78% of all first-time eye care encounters and 66% of all residual eye care or recurring or enduring care. I got those numbers from the American Optometric Association Caring for the Eyes of America publication, if you need that as a reference. When we see how good we're doing, right, we always talk about our business is going great. And if you just were to read this, you'll see that highlighted, our business rating is up, right? Business is up, optical is up. But at the same time, if you keep on reading, you'll see that our professional services are down. So one of the things I want to talk to you about is how you look at your practice. And you're going to hear me talk about this numerous times throughout the course of tonight's presentation, because how you look at your practice is going to be extremely important to what action steps you're going to be able to take to be able to create opportunity out of the disruption that occurs. Now, for fear of offending somebody, I'm just going to apologize ahead of time. But if you pretend that your practice is this beautiful little baby in a baby carriage, and it's just sitting there in front of you in the cradle, you've got this beautiful, gorgeous blanket of optical. If you pull away that optical blanket, many practices will see an ugly baby of professional services. Because you pay attention to your aggregate income, you're not really paying attention to the secular income of professional services as compared to your optical. What I want you to do is to understand that I'm an advocate for both. I think you should have a booming optical business. I also think you should have a booming professional services business, and I think that you should analyze and manage each of them separately. So I want you to start thinking of treating two businesses under the same roof. And why do I want you to do that? Because when we start to talk about the pressures on the eye care professional today, you're going to see that you may employ different business strategies and tactics in your particular community based upon the particular threat or opportunity that presents itself by disruption that's taking place. But you're going to have to be able to understand, you're going to have to use a professional service strategy and tactic in a particular application as compared to an optical strategy and tactic, okay? And you're not going to be able to make those business decisions in a rational manner unless you work from the premise that you're operating two businesses under the same roof. So let's kind of take a look at these different pressures that you have to deal with. And none of these, you'll notice, has anything to do with clinical care. All of the stuff that you spend so much time on in your postgraduate education to make sure you're up to date on how to manage a glaucoma patient or a dry eye patient, or you talk about income opportunities in glaucoma, whatever it may be. All of these pressures that you see here, everything from the Affordable Care Act to the environment that the government is creating for us, and that's both good and bad, right? Opportunity and disruption simultaneously. You'll see that we've got what used to be called meaningful use, PQRS, the quality resource and use reports, the QRUR, the value based modifier, now all have transitioned into something that we call MIPS, the merit incentive based payment system, and we'll get into that in much more detail later on. We understand that we've got disruption and opportunity coming from managed vision care plans at the same time, who may be offering different changes in the product mixes that they are offering to their clients, the employers and individuals who are purchasing managed vision care plans. See, here's the funny thing. I hear a lot of people tell me, "Oh, John, I don't need to worry about this stuff. I am so comfortable. I make a great living from VSP and IMED. They let me do, you know what? I'm booked out 2 months in advance." Right. And you've become drunk and intoxicated on a 55 national average dollar annual comprehensive eye exam with an optical benefit tied to that. Why do you have that? It's because that's what VSP or IMED or Spectera or Davis has sold as a benefit package to whom? The employer, the school district, the bank, right? The local business, the manufacturing plant, whoever it may be. But what if the manufacturing plant comes back and says, "Hey, you know what? I can't afford those premiums. I need something less." So what if they come back to you now and say, "Hey, guess what? We're going to now pay you $30 for a routine eye exam once every couple of years instead of a comprehensive eye exam." And that reimbursement is going to be significantly different than what you're used to. All of a sudden, maybe you just took a 50% hit in income and didn't even know it or had no control over it because you stopped paying attention to what's going on in the environment around you. We all know about alternative or new consumer channels, right? Now, in the past, we first got introduced to them with contact lenses that were available online or through alternative channels. Glasses then soon followed, both spectacles and lenses, right, through various services, whatever it may be, whether it's a Warby Parker or a Zinni Optical or you name it, right? And now what are we starting to see? We're starting to see alternative consumer channels coming with what? Professional services, aren't they? Right? So the biggest deal is this. If you're not analyzing your business as if it was two separate businesses, you're not going to know how to properly prepare a tactical response to those things, or if you're not understanding what that service offering is and is it really something you're competing with or not. But most people have gone into panic mode. I can use the American Optometric Association as an example. I think, this is my personal opinion, okay, is that the AOA took the wrong approach in suing various providers of online refractions. I really think that what they did by doing that was equated an online refraction to a prescription, which in my mind are two completely distinct and separate things. And if we could have had legislation put into place where we actually can control the prescription better, then people could do online refractions to their heart's content, but we still control the prescription at the end of the day. So just another way of thinking about something as we're moving forward. Obviously, we've got huge shifts in the marketplace that are taking place by a lot of forces that are outside of our control. We've got a lot of vertical integration. The classic example of that I can call your attention to is the VSP Premier program, right? VSP is a total entity in and unto itself. They provide insurance services or defined benefits to the consumer, which then provides professional services to the provider, which then provides the fuel or the gasoline for their optical business that fuels their individual frame line, their privately manufactured and branded lenses, and they have software and they have everything else that participates in that vertical integration. They are a completely contained ecosystem, if you will. And then you've got changes in the alliances, things like IDOC and Prima, Vision Source. You've got other My Eye Doctor. You've got all sorts of different things out there that are causing disruptions in the marketplace. All right. So we've got these types of pressures that are on the eye care practitioner that's trying to go out there and survive it on their own. The interesting thing is this, right? These pressures create challenges, and if this is what you're doing, then I'm afraid we've lost the battle. If you say that this stuff doesn't affect you because you're in rural America, or you say, you know what, I'm employed by somebody, I don't have to worry about any of this stuff, I think that you're missing the point, right? Because everybody is going to get affected. If you're in a large group practice, you're still going to get affected by MIPS, even if you as an individual aren't getting represented in the reporting. Okay, there's still changes that are taking place that are going to affect you. I don't want you to hide your head in the sand. I want you to be aware of change and be able to monitor it and manage it effectively so you can use change to your own advantage. Now, many of you
John,
will say...
if I can stop you, we've got just a question on how can we have outcome-based reimbursement without an investigation after the fact, and maybe you're going to come to that, but that's a question that's come up already.
Say one more time, Nathan. How can we have
an outcome-based reimbursement without an investigation after treatment?
So you're going to, as a provider, have to report the quality outcomes that you're tracking. So you as an individual practitioner are the ones for doing all of the reporting. So the post-care is going to be demonstrated through, for example, how many office visits you might have with a glaucoma patient in a given year, and are you able to still maintain a 15% drop in IOP? Let's say, as an example, and I'll refer to this again later in our discussion, but let's say, for example, that two practitioners, Dr. A and Dr. B, they both chose glaucoma as one of the quality measures that they have to report on. Dr. A sees the patient 2 times per year, does 1 visual field and 1 OCT on that patient. He's able to maintain a 15% drop in IOP of his glaucoma patients. Dr. B also chose that same quality measure, and Dr. B sees the patient 5 times a year, does 2 OCTs, 2 visual fields, a fundus photo, ERG, VEP, gonioscopy, and anterior segment OCT. He also was able to maintain a 15% drop in IOP in his quality standards. So who got the best outcomes? Well, what the insurance carrier is really going to look at, to the doctor who asked the question, is one simple thing. Who was more cost-effective and cost-efficient to the system? If Dr. A only cost the system $280 and still got the same outcomes, and Dr. B cost the system $1,585, who's going to be asked to participate in the plan? So you'll see that we're going to now start to be able to take the ICD-10, our quality measures, number of CPT codes, dollar costs, everything is going to come into play in how our quality scores are going to be determined. And when we get to the MIPS section of tonight, I think that will be very evident. Okay? And I will say this, webinars number 2 and 3 will also be covering this in more detail as well. So if you're asking yourself WTF, I want you to understand that WTF really stands for what are the facts. If we don't understand facts, we listen to rumor and innuendo, we don't pay attention to what somebody's saying or ask somebody for a reference before we apply something, now we're running risks in our practice, right? So I want to start talking about some simple truths that we know in our practices. So most optometrists have gotten into practice over the years because they can have control over their professional lives, whether they can control where they want to practice, how they want to practice, their subspecialty, right? They can control their hours, their mobility, all sorts of things, but there's a lot of control that we have in our professional lives. 95% of ODs participate in some form of managed vision care plan. 90% participate in some form of medical plan. Despite our increased scope of practice over the last 40 years, believe it or not, 65% of the average optometric practice's revenues are still coming from optical. Now again, I want you to have a booming, banging optical business and contact lens materials business. But I do want to see professional services as a percentage starting to increase, because if we don't, then we're going to be much more vulnerable to market shifts or market pressures. Optometry practices also utilize extremely high levels of technology, but on the downside, we test to a much higher degree than other medical professionals. Why? Because people have understood that revenue from those additional tests has been a very seductive, attractive thing. Now, that's going to go away. That's going to dissipate because now we're going to be paid upon how efficient and effective we are, not how much tests do we do. And that's a big, big shift that we're going to have to get used to. Two other things that are really important. The model of healthcare delivery is unprecedented territory. We've never been in a quality outcome situation before, and the fee-for-service model that we've traditionally been accustomed to is under attack from all branches of the government, legislators, everywhere in the political system. And also understand that consumer behaviors also tend to drive trends as well. So that means that since the infrastructure in which we practice is changing, we also have to change. Now, I know it's an unpopular word, right? Because that means that your comfort zone is going to be threatened. What you have gotten used to doing every single day for how many years that you've been practicing is now going to be different. I'm sorry. You're absolutely right. It's going to be different. And if you're going to be a survivor, how about this? Let's not be just a survivor. Let's be a thriver instead. Let's understand how this disruption can create an opportunity for you in your clinical practice if you're willing to make some formative change within your practice. But you have to have the right frame of mind. You also have to have the appropriate foundation, resources, network, and confidence in being able to succeed. It also is based upon not trying to change too many things at the same time. It's being able to understand how to prioritize and execute to perfection to be able to make these tactical changes in your practice. So what I'd like you to do is, instead of being afraid of change, learn how to anticipate it, embrace it, and direct it. If you can do those things, opportunity will present itself very, very well. If you don't change, I find there's a very common behavior for individuals who are saying, you know what, I don't want to change. I don't really have to change. You know what, in fact, we're doing fine without even having to change. Guess what? We rationalize our behaviors. We are awesome rationalizers in optometry. And unfortunately, what rationalization leads to is complacency. And when we become complacent, we don't get any difference in outcomes. When we rationalize our behavior, we're saying, hey, you know what, we're really doing okay. That's that beautiful blanket of optical covering the ugly baby of your professional services, because we have to start thinking about our practices differently to be able to survive. So let's talk about some of the disruptors that have been out there, right? Because there's been a lot of things happening in healthcare, but how is it affecting the independent eye care professional? Well, remember, our business is nothing more than supply and demand. I'm sure every single one of us on the call today has experienced wanting to be on a particular managed vision care plan and being told, I'm sorry, we already have enough providers on our panel, but thank you very much. But I have to get on the plan. The school district just signed with that plan and I need to get on it. Thank you so much for your interest. We've already got enough providers on the plan. Well, here's what's happening in healthcare in a macro sense. Anthem and Cigna, Aetna and Humana are merging. United Healthcare, single standing lone provider out there. Now, the Department of Justice has not only put those things on hold, they in fact have said, guess what? We think that this is going to create unfair competition, too few providers in the marketplace, and that's not good for competition, not good for business. So fortunately, just a couple of weeks ago, those were stopped. But there's other types of changes that are taking place. Superior Vision was acquired by Centerbridge Partners. Now you're probably going, I don't know who in the heck Centerbridge is. Of course you wouldn't. They're nothing more than a financial player. They're a private equity group that came in and said, guess what? We've got money and we want to buy your cash flow. Kaiser Permanente, a closed HMO that started in the Southern California market, went up to Seattle and signed Group Health, or acquired Group Health. Now you'd probably say, John, who cares about that? And that's not a big deal. Well, it really would have been if 75% of my income came from Group Health members that lived in my bedroom community within a 3-mile radius of my practice and constituted 75% of my revenues. Overnight, by the signing of a pen, I no longer am a group health provider. So understand that these types of things are happening, but you have to be hyper aware of them so that way you can know how to create a strategic and tactical response to these things. As you know, my eye doctor is a East Coast-based chain started in the Washington, D.C., Virginia area and has really expanded up and down the East Coast. You know, they're going to be close to 400 practices here by the end of the year, 450 practices by the end of the year. It's absolutely huge. I have many of my colleagues who've actually sold out to them. Maybe it's for them, maybe it's not, maybe it's for you, maybe it's not. I have no idea, but this is affecting the market in which you practice, and you have to be aware of these changes. You've got other types of partnerships that are coming that we have never would have imagined in the wildest dreams. You know, Clarkson Eye Care out of St. Louis acquiring Eye Care Associates and Pinnacle Optical. Warby Parker partnering with Nordstrom's, getting, would you call it maybe an unfair advantage by being able to have greater points of touch with the consumer rather than coming to your practice. I'm going to buy a suit, and you know what? I'd like to go ahead and buy a couple of pairs of glasses and donate one to charity and all of that sort of thing, right? These are things that are happening, you know, in plain sight that we have to understand how to deal with, right? You've got VSP. Yes, Nathan, sorry. Go ahead.
Trying to find the breath. There's a question, how does the practice find out if they're eligible or not for MIPS if they haven't been notified either way?
Oh, you will not be notified. It's up to you to qualify, okay? MIPS, Medicare has already put out all of the documentation, and I'll show you the website here in just a few minutes so that way you can know exactly what to do and how to do it. It's very simple, but you don't apply to MIPS. You're automatically required if you meet a double, there's two standards that you have to meet in order to be required to qualify for MIPS. So you're not, it's not something you apply to or they notify you of. They've already done all the notification, by the way. So it started January 1 of 2017. So don't panic yet, but we'll go over those things in just a moment. But as you can see from the different things on the screen, right, there's a lot of changes that are taking place that will affect the independent practitioner. What I want to make sure you do is are receptive to these types of challenges and understanding that you can have control over it. Now you have VSP actually putting clinics on major company campuses, right? Cisco Systems in California, Intel, right, doing it at UC Vision Plan, right on the campus. You've got Essilor and Luxottica combining. Huge changes, right, in the infrastructure of what's going on. Many people think this is going to be destructive. Many people think this is going to be very constructive for the marketplace. I tend to be on the constructive side of things, but that's just one guy's opinion, right? But it is changing the marketplace of how we're dealing with things in our individual practices. Add on top of that, we've got regulatory demands that are also confusing a lot of things. And if we start to think back into the different things that have been going on for the past, I guess I'm going to go now 13 years, right? If we start to think about the Affordable Care Act, mandatory use of EHR, the quality reporting through both PQRI, PQRS, QRUR, the adoption of meaningful use, the impact of narrow networks or ACOs, accountable care organizations in the marketplace, the true impact of the ICD-10, DRGs, or what I could refer to as capitation by diagnosis, which is a payment system that we will probably be ultimately moving towards. And then my MIPS score, right? 0 to 100, where do I rank? Because if I don't make the cut here in my MIPS score, I may wake up and say, I don't have any people to see. I could be surrounded by 300,000 people, but guess what? I'm not on their plan because my score, my quality was not good enough to make the cut to be part of the plan. So you have to understand that you are going to be judged and ranked along with every other physician in the United States. So this rapid consolidation, the vertical integration, the carriers that are now competitors may lead to a feel of a loss of control and a devaluing asset. What I want you to do is to understand that the reality stops right here. I don't want you to feel like you've got a loss of control or the asset your practice is devaluing in any way. You have the ability to change this and stop the change cycle right there. But we do know that there are pressures, right? Audits are increasing, both from refractive and medical carriers. There is intense scrutiny from medical carriers for the individual physician to demonstrate true medical necessity for all of the testing that we're doing. So if you're ordering an OCT and a VEP and a fundus photo and a visual field on a patient, you sure as heck better have immaculate clinical records that are demonstrating why those tests need to be done and how they're going to add to the outcome for that individual patient. Comprehensive exams, 92004 and 92014, are under attack for overutilization by the federal government. The Office of Inspector General has been investigating optometrists and ophthalmologists for overutilization of the comprehensive eye exam codes. We are not following the CPT rules that say it is our obligation as a physician to use the most appropriate CPT code for the clinical presentation that the patient has. You don't have the right to do a comprehensive exam on every patient on an annual visit. Not with medical insurances. You can do it if it's a prepaid contract through VSP or IMED or whatever. But under a medical plan, you're encumbered to use the level of service that is commensurate with the patient's presentation on that particular day. Whether they've had a comprehensive exam in the last 2 years, 3 years, 5 years, 10 years, it doesn't matter. You still have to see them that particular day and use the appropriate level of service for what they saw you for, and then advise them that they need a comprehensive exam if it's been too long in your professional opinion. Routine exams versus comprehensive exams are going to be much more prevalent. That's going to lead to reduced dollars. You're going to have increased competition between the managed vision care providers for covered lives out there. What happens when there's competition for people? It's all dependent upon premium and amount of monthly, what it's going to cost per patient per month. And so you're going to see decreased reimbursements, right? Carriers are dictating on us how to practice, what we can do, when we can do it, that sort of thing. And automation is a driving force and will continue to challenge the traditional practice model. I want you to start thinking right now. Here's a very important thought. What test do you do? Well, what does your eye exam consist of today that cannot be replaced by technology? I just want you to think about that. We'll talk about that a little bit later in ensuing webinars that we're going to do. But automation can basically replace the optometrist in the clinical data collection. What really separates you is your intellectual property and your ability to analyze the data, not capture the data. So I want you to start thinking about that as well, because these trends that are happening, these futuristic things, are not so much in the future anymore. They're happening now, and it's causing these types of changes. We have downward pressure on refractive reimbursements, not medical reimbursements. Medical reimbursements have actually been constant to higher for the past 10 years. There's increasing demand for care, right? The demand for eye care and optometry's ability to fill that gap is absolutely enormous because of the contracting supply of ophthalmologists that are out there. There is going to be more patient paid directly to the healthcare provider. Why? Higher deductibles, more diagnostics are going to be covered by the patient rather than the insurance carrier. Certain treatments may not be within the coverage boundaries of what the patient actually purchased as far as insurance goes. Patients are more savvy. They know where to look. They know how to get educated due to the internet. So that means that we have to have better technology, better staff. It may lead to learning how to consolidate our practices so we can get economies of scale. And we have to be aware that there's continual changes in the healthcare delivery system. So managed vision care, as I stated earlier, right, is really just a supply and demand issue where your profitability is going to be controlled through mechanisms of controlled distribution and contractual limitations, right? So I want you to start thinking about it with your business head. as far as the services side and the optical revenue side of your business. And that means you need to know your numbers. And so I want you to start thinking of your revenue in a little different way. It's not just how you make your money, it's what you make your money on. How much on services versus materials? From your material revenue, how are you breaking down your managed vision care reimbursements for materials and sales versus individuals who are paying out of pocket? On your service breakdown, if I took the entire universe of services that you're providing, how much is from a managed vision care plan versus medical eye care from your medical carriers versus private pay? We need to know each one of those variables because we have to understand how it fits into the cost system. Now, you know the old concept of chair cost, right? You were involved with that in school. This is going to be vastly important as we go forward, right? There's a lot of different things that you need to know how to look at, but you're going to need to know what it costs you to provide your care on a cost per minute basis. Now, right now, the national average is about $1.65 per minute is what you need to generate from professional services every minute of every day just to break even, right? So I want you to start thinking about that in different terms. Let me just give you an example, right? If you're not understanding what it's costing you to provide your care, there's absolutely no way that you know how to schedule your time or how to accept a particular plan, right? Because this race to zero is going to be a very important concept. If I'm getting paid $50 per examination, right, and I'm only seeing 2 exams per hour, either I'm going to have to learn how to improve my volume to improve my profit or increase my reimbursement, right? So which one of these triangles am I going to do? Now remember, a couple years ago, I think it was October 2015, IMED came out and reduced your reimbursement on average from $50 to $40. That's a 20% reduction in reimbursement. If I didn't change how I scheduled my IMED patients, if I am still booking them 2 per hour, and it's costing me $99.20 to keep my office open per hour, I'm losing $20 an hour. But if I knew that I had a 40% or a 20% reduction here, so I reduced my time commitment commensurately, and I said, okay, all IMED patients get 15 minutes of doctor time, not reducing the amount of testing that I'm doing. I'm still fulfilling all of my contractual requirements. I'm just allocating my time differently, so now I can see 4 IMED patients in an hour. Maybe I'll still see 3 VSP patients in an hour, and maybe I'll see 10 medical patients in an hour. Oh, but John, that means I've got to break my schedule down differently. Yes, it does. That may be one of the formative changes that you have to make because this disruption is creating greater opportunity for you to segment your practice in a different way, right? Because in the healthcare system of today means that we are mandated to see more people at a lower cost and demonstrate higher quality. That's a difficult triad to achieve. Some may call it impossible. I would tell you that it's difficult but not impossible to do. But that means we have to deliver care in a different way than we're used to doing it, and the traditional model is not going to be an effective strategy for your practice to survive in the future. And that means you have to operate from a basis of learning how to delegate, that you as the OD are not going to be the primary data collector any longer. You're going to have to learn perhaps to delegate refraction. You'll still be doing the health examination for the most part, but the data gathering will be done by others within your practice. Guess what? This is not a new concept. Primary care has been doing it for a long time. The average primary care practice, the doctor's only seeing the patient once every 3 to 5 years, and the patient is being managed by other professionals within the practice. Now, I'm not advocating that in your practice. I'm just saying you're going to have to change the way that you're going to see patients and how you're going to collect the data to manage their clinical cases, right? Because our payment system is changing. So, before you just willy-nilly go out there and start changing what you do, please never violate your state law. We are still a state-by-state legislated profession. You have to know what your individual state allows you to delegate and knows whether you can't. All right. My guess is as we move forward, our state laws are also going to change, and our state boards are going to be able to allow us to do things in a much more efficient and effective way without compromising the health, safety, or quality of the care that we provide to our patients. You're going to have to learn your cost per minute. You're going to know how to schedule and process a patient. And if you're not hitting your marks or your numbers, guess what? Start timing what you're doing. Change your process. Time it again. Learn how to schedule yourself differently for different types of care. Instead of saying, well, our time units are 15 minutes, well, that's maybe good for some things, right? Maybe it's 15 minutes for a comprehensive exam for a, doctor time, but maybe you only need 6 to 8 minutes of doctor time to process a medical patient. Well, maybe I can get 10 medical office visits in a given hour if I can teach my staff how to process the patient properly, right? But you never learned this in school, so that means you're going to have to change how you're scheduling and how you're doing things to be able to be effective tomorrow. And also that means greater communication skills, because now you're going to be doing something different that your patient is not used to when they've seen you before. Doctor, you used to spend so much time with me. What happened? You're going to have to learn how to explain that. I never knew that your staff did this. I never knew that you could do that. These are all opportunities that this disruption is providing. So what is MIPS? So last April, we had the MACRA, the Medicare Access and CHIPS Reauthorization Act, pass, and it mandated that we changed our payment system, right? So currently, our payment systems are going to either reward or penalize doctors based upon measures of quality and the ability to demonstrate certain practice improvement capacities in a practice. Our payment period starts 2019, but our data collection started on January 1 of 2017, okay? So this website, we're going to go to it right now in real time so you can see this, okay? But I want you to know, and I want you to write this website address down. For those of you who are just listening, I'm going to read it to you. https://QPP.cms.gov. You can also just Google the CMS Quality Payment Program. Now, when you go to the site, it's really quite impressive. The site itself, if it'll open up here on our screen, okay, that's what the quality program website looks like. I want you to know that it describes things very, very, very well. So it talks about what's in the quality program, and to get to the doctor's question earlier, who is in the quality program? What do you need to do to be mandatorily part of it, or what lets you be exempt? So in order to be in the program for 2019 and to qualify in 2017, you have to bill more than $30,000 in the Medicare program. So I'm sorry about that. Bill more than $30,000 and provide care for more than 100 Medicare patients per year. Notice that it says you must meet both the minimum billing of $30,000 in Part B allowed charges and 100 patients to be in the program. If you are below either one of those, you are not in the program and you are exempt. You must also be considered a physician by Medicare, which, as you know, April 1, 1987, optometry got their designated physician status. Okay? Here is the calendar. So 2017 is the year that we have to perform all of the quality measures. We then have to submit those by March 31st of 2018. In 2018, Medicare will give you feedback and is going to tell you how your payments are going to be either upwardly adjusted with a premium or downwardly adjusted with a penalty for all federal payments made to you in 2019. Okay? This website is absolutely fabulous. One of the things that you can also do is click on the Explore Measures at the very top, and it will actually tell you, here's the MIPS overview, here's the quality, here's the improvement activities, here's the advancing care information, or what used to be meaningful use, and here's the cost program. Now, all of that is in the Learn About the Program. It tells you quality replaced PQRS, improvement activities were a brand new category, ACI, or advancing care information, is what replaced meaningful use, and cost replaced what we have as a value-based modifier. They tell you actually how these are going to be done in each given category. Now, here's the great thing. Under the Explore Measures tab, you can actually go and say, okay, here's my program performance, here's how the weighted average is going to be done. Quality represents 60% of your score, advancing care information or meaningful use is 25% of your score, and improvement activities is 15%. Well, how do I do that? If I clicked on the quality measures, I can actually do an interview. So I have all of my printed instructions right here. Very simple. I'm going to go down here and it says there's 271 measures. I want to look at the specialty measure set for ophthalmology. So I click that. You'll notice that I'm now only showing 21 measures out of that, and I can say which ones apply to me. Well, I'm going to do the age-related macular degeneration counseling on antioxidant supplements. Okay? I want to add the dilated macular examination for age-related AMD. I'm going to go down and I'm going to see, I'm going to like to do the closing the referral loop, receipt of a specialist report. I want to do the diabetic eye exam. I'd like to do diabetic retinopathy, communication with the physician managing ongoing diabetes. I want to do the diabetic retinopathy. I want to do the documentation of current medications in the medical record. I want to do preventive and care screening for high blood pressure, right? Tobacco use, primary open-angle glaucoma, right? Optic nerve evaluation and IOP. Tobacco use and cessation amongst adolescents. And guess what? It summed all those up, and I can actually download those in a Excel spreadsheet that will now allow me to know exactly what I need to do and how I need to do it. And I then can simply go on to my next part of the interview, advancing care information. And it tells me again, what do I need to do? Right? And it tells me right there all of the different things that I can add. And this will build your own compliance list for you as you go through each of these different sequential interviews. So I would tell you that this website is a godsend, and I'm not very complimentary of the government most of the time, but you know what? They did a really good job. And this is one thing that I would have you go through first, your compliance officer in your practice, and everybody in your practice understand what this program is all about. Because you know what's going to happen? This is going to determine how you're going to get paid 2 years in the future. So what we want to make sure is that you're doing the best job that you can do today, so that way you actually get an upgraded payment, right, and a high score. So when we start to think about how this score is being done, the maximum score you can get is 100. And if you don't do anything at all in 2017, you will automatically get a 4% adjustment downward to all of your federal payments. Now you may say, who cares, John? I'm not a big Medicare provider anyways. 4% of $30,000, that's not even worth my time. Understand that this is going to apply to all medical insurance carriers. Medicare is just the first one formally putting this program out, but every other carrier is going to eventually move to this as well. Here's the thing that's really important. Medicare will publish your score 12 months after the performance year. So you qualify in 2017, you're going to get published in 2018, paid in 2019. Here's the other kicker. For the first time, consumers are going to see how you're rated on quality as compared to your peer groups. Insurance carriers are going to see how you're rated on quality outcomes compared to your peer group. You may not make the cut if you don't have a high enough quality score, or patients may be disincentivized to see you if you don't have a good enough quality score. You may have an alternative payment program from a managed vision care company if you don't have a good quality score. So establishing your quality is going to be critical to your survival going forward in our healthcare system. So remember that MIPS is the combination of your quality score, how cost effective you are, your clinical practice improvement activities, your advancing care information or your meaningful use score, and the sum of those four things together is what's going to give you your merit incentive-based payment system score. The best you can achieve is 100. So when we talk about these challenges, yes, Nathan?
For an older practice owner who may not be eligible for MIPS, as he looks towards his transition planning, what might the impact on his practice be in terms of evaluation in the future for not having participated in MIPS now because he's ineligible?
So if he doesn't qualify for MIPS, his payments won't be affected. He won't even be visible, right? He'll be invisible under MIPS. He may be invisible to other carriers as well because they're going to be relying on the MIPS program. So it's unknown at this point in time the impact from the managed vision care side of things. But from the medical side of things, from Medicare's perspective right now, he would not, that individual would not be affected, okay, at that point in time.
Okay.
So again, these challenges that are there, right, they do require us to look at our practices differently. They do require that you try to understand that change is happening whether you like it or whether you don't, whether you believe John Rumpakis or whether you don't. Change is happening under the surface, even if it's not readily visible in your community. This legislation, all of these programs have already been put into place. They're already law. They're already moving forward. As an example, when we talk about other healthcare insurers, Humana, oh my gosh, I'm totally blanking out. I apologize. One of the major carriers invested $78 billion. Oh, it was Anthem. Anthem Healthcare invested $78 billion in their own outcome-based technology and computer algorithms to start determining how they're going to start paying physicians. So remember, what you do with your patient is not going to necessarily determine what you get paid. If I do 10 tests, it could actually adversely affect my score when really only 1 or 2 tests were necessary because they're going to look at me as a cost center within the system and not an efficiency center within the system. So how you approach this in your practice is going to be critical. So what I want you to understand is that you have to adapt. It's not a choice, it's a mandate, right? You may think that we've got a lock on this marketplace, or you may say, I don't do enough medical care to even worry about it. This is going to affect all aspects of your practice, and it's going to affect consumers' behavior, right? And consumers' behavior is what really drives many of these changes also. So you all know that you've taken advantage of disruption out there. There's probably not one of you out there that hasn't bought something on Amazon because you said, you know what? I can go get it at the store, but to have it delivered to my house in 48 hours for free is great. You may say, you know what? That changed how I do everything. If you're a Starbucks addict like I am, You may say, my God, I've got this application on my phone. I can pre-order, go pick up. I don't even have to talk to anybody. I love it, right? It changed how we do things. This is also a paradigm shift in healthcare. How consumers will get their eye care is going to change. They're going to now look at providers based upon their quality ranking. They're going to look at them by their technology. They're going to look at them by their accessibility. All of these different things are going to be formative changes to our practice. What I want you to understand coming out of tonight is that maintaining the traditional optometric model of delivering care will not be an effective strategy for prosperity in the future, okay? You're going to have to learn how to adapt and create a healthcare team within your practice. You're going to have to learn how to use your network within IDOC as a resource to be able to really develop those skill sets, the training, the ongoing knowledge base to be able to be an effective competitor in your market. Now, what's the strategic uptake on this? If you can be the first one to be the leader in your community, I guarantee you, you're the one that's going to be able to be most recognizable to the healthcare systems that are out there and will probably get the early lead on being able to get covered lives who can come and see you. If you sit and just wait for these things to happen and you say, you know what, I'm going to wait for things to shake out and see what goes on, I'm afraid that the world's going to pass you by. I'm afraid that you may not be registering on people's radars early enough. And remember, this is ultimately a question of supply and demand, just like any business equation is. And what we're seeing is the typical business cycle application to healthcare. The same thing that happened in automobiles over 100 years ago. The same thing that happened to laptops and technology 2 decades ago. The same thing that happened to services now, where we can buy most of them on the internet. That's happened within the last decade or so. We're seeing this simply applied to medicine. I want you, as an independent eye care professional, to be the best prepared that you can be to go out there and take advantage of these opportunities that this disruption is creating. So with that, I'm going to say thank you. Nathan, any other questions that came in? Not hearing anything. I'm going to assume that there's no additional questions that have come in.
We do have 2 more questions.
Oh, sure.
First, is there a place that has practice statistics of Medicare dollars and the number of patients treated?
Yes, there are a number of sites that you can go to. Let me just, if I can, go to, let's see if I can go to my web browser here. Sorry, I may have to just exit out of this real quickly. Let me go to a site that I enjoy going to. It's called ProPublica.org. So P-R-O-P-U-B as in boy, L-I-C-A.org. And what ProPublica does, ProPublica actually has the government statistics. Now, you can go find these on Medicare's website as well if you'd like. But I go here and I click on the Data tab. I go down to clicking Examining Medicare. And then I go to Treatment Tracker. And then any doctor here is actually able to look up all of their own data if they like. They can actually look up data based upon their individual state as well. We'll wait for this to open up here. I'm afraid that I think my internet is slowed down by doing the online webinar. But let's say I wanted to look at the state of Arizona, for example, and I wanted to just look at I'm going to go ahead and I want to search optometrist in Arizona. And I'm going to click on optometrist here, and it's going to now tell me who the physician is, how many services they did, how many patients they saw, how much their payments were, what their average payment per patient was, and their average number of services per patient. Now, I'll just do a quick ranking here, and so let's say maybe we can do here. So I don't know who this individual is. 816 services on 86 patients, $508 per patient, 9 services per patient. I can actually click on the individual and I can actually see what those clinical tests were that they did. So sensory motor exam, office visit, visual training, office visit were the services that they did. So I could tell how much it was done, how many times it was done, how many patients, what they were paid. So that's one of the sites, Nathan, that I go to with regularity.
Okay, thanks.
What was the other question?
The last question was, if you are an AOA more, do you still list your codes on your Medicare claims?
Great question. So doing a claim-based submission versus a registry-based submission. So I guess it depends. I mean, I'm going to give a wishy-washy answer to the question, okay, and I apologize. I would have to check with Prometheus Research, who is a subcontractor that the AOA subcontracts with, because their data extraction is a little bit different for each EHR that they contract with. So I can't answer that question specifically with 100% accuracy. What I would do is I would contact Prometheus Research or contact your EHR manufacturer and find out, do you still have to do claims-based reporting for certain things if you're a more client? My understanding is that the registry is supposed to replace the claims-based reporting, but I have seen certain circumstances where that's not actually happening the way that the doctor thought it was supposed to be happening, and they're finding themselves not reporting certain things that they thought that they were reporting through the registry extract. Anything else? Nate, anything else from you, Nathan?
No more questions on my end.
Okay. Well, I'd like to thank everybody for attending tonight. Remember, tonight's webinar will be on the IDOC website probably within the next week or so. It'll be resident there for 90 days, so you and your staff can watch it again, download it. Tonight's was number 1 of 8. Please go to the IDOC website or contact IDOC, and you can get details for our upcoming schedule and topics per webinar. And Nate, thank you for spending your evening as well with us as well, Nathan, on doing that. I know you're taking time away from family. And to the rest of you, have a good evening as well. Take care.